Good evening. This is Xu Zhaojun again. We're now still in the epicenter of the coronavirus at the city of Wuhan. We're doing another round of cross-nation medical consultation conference. And tonight, I'm still with the doctors of the Peking Union Medical College Hospital. And on the other end of the internet, we have dozens of doctors in Israel and an expert of EU on disease control. And we have a doctor from the United States, but I cannot really tell which one he is. Anyway, we'll do the same thing. We'll make a very short brief for the doctors on the other side of the internet, and then we'll take questions from our colleagues in Israel and the EU. Since we have so many doctors on the screen, I'm afraid there should be about 30 or 20 of them. But the very first one make the appointment with CGTN about this meeting is our expert from the EU. So we'll after the briefing, we'll give the EU expert the very first opportunity to raise questions. Is that okay for you? Sure? Okay, good. All right. So now the floor is yours.
Okay.
All right. The first one is
that's me. Okay, Dr. Wu.
Dr. Wu.
Hello, everyone.
Okay.
I'm Dr. Wu from Peking Union Medical College Hospital. Actually, I'm a cardiology doctor. I arrived in Wuhan last month, and there's 185 healthcare providers from Peking Union Medical College Hospital taking charge new built ICU ward. And this ICU had 32 beds, 32 ventilators, 6 blood purification machines, 2 or 3 bedside echo machine, and 2 ECMOs. And in this multidisciplinary team, there were 44 doctors, 133 nurses, 3 laboratory technicians, and 5 director or secretaries. We are working hard in the last 2 months and save lives. Thank you.
Hi, everyone. I'm Jing Xie from Peking Union Medical College Hospital, Department of Infectious Diseases. I have been working here in Wuhan for almost 1.5 months. Here, I work as a member of the laboratory service group. We provide point-of-care testing for our patients and also for our medical staff. First of all, I want to share with you, I think the most important thing is a diagnosis and test. I think diagnosis of COVID-19 is a comprehensive and dynamic process rather than relying on certain type of lab test. I want to repeat, the most important thing, in my opinion, is to differentiate patients from flu or other pneumonia without missing any real patients to avoid spreading.
Hello, everyone. I'm Dr. Ding from Peking Union Medical College Hospital, and I worked in the Department of Critical Care Medicine for many years. And now I'm working as an attending physician in this ICU ward and responsible for the treatment of critical care patients. And as an ICU doctor, I have some experience to share with you, because I think the basic support therapy in the ICU is still the key of the treatment of this disease. As it is a new disease that we never met before, the attention of the doctors are easily to be diverted to trying to find some specific power antivirus drugs. But till now, we don't have any powerful antiviral drugs proven to be very effective in these patients, especially in the critical ill patients. So we have to focus on the basic support therapy as usual. That includes ensuring sufficient calorie intake, monitoring their water and electrolyte balance to maintain internal environment stability, and treating underlying diseases to provide adequate organ support. Thank you.
Hello, everyone. I'm Dr. Fan, also from Peking Union Medical College Hospital. I'm a pulmonologist, and also I do critical care medicine as well. I agree with all my colleagues has said. I believe COVID-19 is a very tough disease, epidemiologically and clinically. No matter in the outpatient setting, inpatient setting, ICU setting, it can all cause a lot of difficulties in treating and caring for such patients. If you have specific questions, we are just open. You can just feel free to ask us. We'll provide you guys with our perspective and experience, and we hope it works.
Okay, we have some questions from the internet.
Okay.
And we start the question and answer section, okay?
Yes.
Well, we've got a question, two questions from the Lesham, from Dr. Lesham. He firstly asked, what,
because the EU expert is using Skype, so we have to put the computer a bit close to you.
Dr. Lesham has raised the two questions. First one is the efficacy of chloroquine, a medicine with evidence, with certain amount of evidence. Second question is, what masks did we use? Surgical N95. Okay, I will take the second question since it's simpler. Well, usually, as you can see, in the ordinary live setting, we will just wear a surgical mask. But in the setting of ICU, also in the inpatient setting, when we approach patients with COVID-19, we will wear N95 plus personal protection equipment. It's kind of strict here. Thus, we are no people from the support medical team all over the country were infected. That's what we do. But in ordinary live setting, when we stay in the hotel, we just wear surgical masks if we have to, stay with people. How about second question, chloroquine?
Chloroquine.
Who is going to answer that?
Do you have any opinion?
Well, okay, I'll try to answer the chloroquine. Yes, we have obtained some, we have received some information about the efficacy of chloroquine. But frankly speaking, we have no experience in using it. Just because, well, as pulmonologists, we use chloroquine sometimes because you will have like patients with interstitial lung diseases, which maybe benefit from chloroquine. But in our opinion, it's a very soft drug. It's not as strong as immunodepressants. So we kind of believe that among critical patients, this medicine is not likely to be useful. So we do not have too much experience using this, treating our ICU patients.
Regarding the mask question, I want to add some important information. Actually, there are more than 40,000 healthcare providers come to Wuhan to support their local institution to fight against COVID-19 with their properly used PPE. There are no one get infected. So no healthcare associated infection happened among these more than 40,000 healthcare workers up to now.
Okay. Hold on a minute. At the beginning, I said, according to the sequence I made at the beginning, I think the expert from the EU should raise their question first. So I will I'll ask this gentleman from European Union to raise your question for the doctors of the Peking Union Hospital. All right? Okay. Now you're. Yep.
Thank you very much. Can you hear me?
Yes.
Hi, my name is Piotr Kramars. I work for the European Center for Disease Prevention and Control, the European CDC. I'm a physician by training, but this is a disease control center, so we do epidemiology and public health. But I have some questions, and I would like to start by thanking you very much for organizing this and sharing all this knowledge. This is much, much appreciated. Thank you very much.
It's our pleasure.
Like and please stop me if I have too many questions, but I would like to start to ask you, how did you organize the triage of the patients that would enter the emergency rooms during the influenza season? I guess there were many such patients, and you had to divide them somehow into those with respiratory symptoms and not. How did you organize such a triage?
Okay, so you ask the triage of the fever patient. Okay.
Yes.
Yeah, I think most of the hospital in China now have the fever clinic. So the patient with the fever, they need to go to the fever clinic to screen for like flu A, flu B, and COVID-19 and other virus infection. So before the test comes out, they cannot leave the fever clinic. And then we will divide the patient. And they usually they can do the CT scan in an hour in the fever clinic. So when we collected all data, we can divide the patient and send to the other place, or could be isolated if they are positive.
Basically, we
Thank
can.
you. My next question is. Okay. My next question is, what were the criteria for de-isolating patients after they have recovered? What criteria did you use to stop isolation when patients recovered?
Okay. For the criteria for de-isolating patients after they recovered, first, normal body temperature for at least 3 days. Second, significantly recovered respiratory symptoms. Third, obvious absorption and recovery of acute lesion in the lung imaging. The fourth, negative result of the nucleic acid test of the virus for consecutive 2 times with at least 24 hours of sampling interval.
Thank you. This is great. My third question is, how did you organize the care of mild cases? I guess some of them, there was a home care of these cases. How did you organize this?
Well, sir, thank you for the question. I have some more comments about the isolation question you just raised now. Just raised. Well, actually, when people meet the criteria for discharge, we will still isolate them or keep them, untouched for 2 more weeks, just to make sure. And also, the government is organizing some epidemiological investigations and testing the antibodies to make sure they do not recur, the disease do not recur. The third question is about the patients treating with mild diseases. Well, we have created a concept or a facility called module hospitals, which are modified from domestic facilities such as gymnasium, or stadium, or gym. So mild disease patients can be quarantined and provided with necessary care. They were treated well by medical staff all from the country because they have mild diseases. So the facility and the medical resources they have to use is very limited. So the beds of the module hospitals can be augmented very quickly. And also the transferring system or transferring strategy is very very well organized. If the patients get a severe disease or from mild to severe, they will be transferred to hospitals. And if they got critical diseases, they will be transferred to ICU, such like our ICU. That's how we organize those patients, module hospitals.
Okay, thank you very much. My first question is about hospital outbreaks. We saw some publications from the early phase of the epidemic from Wuhan that there was some spread in the hospitals among staff. What kind of hospital outbreaks have you seen, and what was the most effective way of dealing with them in your experience? Over.
Okay, we were quite concerned about the inside hospital outbreaks. We call it nosocomial infections. We also know friends or colleagues who get infected from hospital patients. But it was all on the initial stage when the medical staff does not know too much about this disease, about the virulence, about the transmission, about the protection. Actually, when we arrived in Wuhan, we have did some investigation or survey on medical staff we know here in Wuhan. What they told us is when we got to know more about this disease, they have applied a strict isolation strategy and protection for medical staff, and so the inside hospital spread to medical staff has been largely cut down. Moreover, we have applied more than 40,000 medical staff from all over the country, more than 30 provinces. They stay here for more than 1 month, commonly, and none of them were infected, as we know. So we believe appropriate isolation and appropriate personal protection is sufficient to keep medical staff who are caring for the patients from getting infected.
Thank you. I have another question. What is observed in Europe in some of the hospitals is that actually people who end up being in intensive care treatment, initially we thought that they are usually elderly with some underlying conditions, comorbid conditions. But now there are some reports appearing that quite a few of them are actually younger than 60 years of age and without underlying conditions. Have you observed something like this?
Yeah.
And can you comment on this? This would be very
说
useful.
年轻人没什么
Over.
疾病也重症了，也有。
你要来吗？还是我？
听听嘛，也有。
我可以跟他们一块来。
我先说一下。Okay, well, we have some younger patients under the age of 65 and without any underlying diseases. But that doesn't mean the disease is not severe in these patients because, as we know, the main manifestation of this disease is the lung, and these patients suffered from severe respiratory distress, we call it AIDS, but because they are young, the underlying diseases, they don't have any underlying diseases, and the complication of this patient will be fewer than the others. So if we insist to make the patient recover from the AIDS, they can recover sooner than the older patients, and that's our experience.
Okay, I can give you some information of my investigation in the recent month. There are 77 patients in this world I have investigated in the ICU, and the youngest one is 26 years old. 26 have any pre-existing disease. Okay, the mean age of the 77 patient is 65. 65, the mean age. And the youngest patient who died from COVID-19 is 47 years old. Okay.
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 Thank you very much.
Thank you.
Could you comment? Sorry.
Any more comments?
Could you comment on the role of children in transmitting the disease? This is an open question. There is a lot of discussion. We know that they can get infected, but they don't develop severe disease. Do you have any observations how efficient the transmission is from children? This is a more and more important question for us. Now, as the countries consider school closures, or actually have undertaken school closures in Europe. Over.
Me again.
Your people had a recurrent disease after
这是啥呀？
就你上次回答。
All of them are adults. Also, there are concerns about about
Area of this
school age,
patient 刚才说过。
school age.
就是 criteria
And now we are sure, just
Here
as
we
you
are.
said, that they can
Are
be
releasing.
infected, but most of them have mild diseases. Whether they can pass the disease to others, there are family questions. It's hard for us. It's kind of hard for us to evaluate how is the disease severe, more severe in pediatric patient. Our strategy is if we have pediatric patients, we isolate and treat them. We treat them like adult patients. We don't judge them like they are safer than adult patients. We just apply similar criteria for isolation and treatment and follow-up.
Okay, and also I have a question because of course it's not only in Europe but all over the world. The countries are facing now a number of countries are facing increasing and fast increasing numbers of infections, and of course there is a worry about the capacity of the ICUs to treat such patients. You know, the capacity to have the sufficient number of ventilators, sufficient number of staff, etc. I guess you went through this. How did you manage these increased pressures in your setting? Over.
So this is your last question because we have a lot more doctors still waiting online. All right, the doctors from the Union Hospital will answer that question. Then we'll give the opportunity to other doctors. Okay.
Sorry, it's a bit hard to hear you. So I'm sorry.
Okay, so this will be your last question. All right.
Yes.
Okay. Good. Thank you very much. Thank you.
Okay.
Sorry for having so many questions.
Okay, it's my honor to answer your last question. You know, a lot of people, there's an increase in people getting critically ill. So how, your question is the initial question that Wuhan has faced in the last 2 months. So, but we are lucky that China is a big country. So we send about more than 10% of ICU doctor and the pulmonary and the critical care medicine doctors from all over China into Wuhan, in the Hubei province. And each big hospital, there are new built ICU ward, urgently established. So just like in this, in Tongji Hospital, that's a Sino-French new city campus, 185 health provider from PUMC Hospital taking charge of the whole new ICU. I think you need to prepare more.
Thank you very much for answering all these questions. I'm very grateful for that.
Someone take question.
Okay, we'll take questions from the Israeli doctors. All right. Since there are so many
Question.
do you?
Insights.
The question are all there. But excuse me. We would like those doctors to read out their questions so that more people can hear about it. All right. So can you choose one of them, any one of them to? Oh yes, okay. The question is over there. Right.
So,
Can you read out the question?
left,
Please? Okay, I will read
No,
the
no, no,
question.
that's-
I will
no,
read
that's
the
not-
question for you. Okay.
you can,
insights. 上面的回答过 insights.
Okay. And the one with the Galaxy A8 Plus asked some question about the insights. But can you?
不能投屏吗? Can we?
投在屏上。
Yes. Can we put the question?
Yes, yes, we can hear you.
Okay. Hello, I'm Rosen from Israel. At first, I want to thank you very much about your encouragement doing this meeting and sharing us your experience in the disease. What I want to ask is your experience with the NSAIDs treatment in the patients with coronavirus positive. What do you have seen for side effects with this treatment? We saw that the World Health Organization declared that this treatment is not recommended for the coronavirus patients. What can you tell us about that?
Well, thank you for the question. Well, we have seen the recommendation from WHO too, but we have to, well, describe this problem in two ways. The first one is, are we using insights if the patient have very high fever in COVID-19 patients? Yes, we do. Especially in ICU patients, we use insights from time to time to solve the temperature problem. We believe for ICU patients, the risk of insights are generally in the effect on kidney functions, but it's moderate. We can control that. We can accept that. Secondly, are we using insights specifically for the treatment of COVID-19? No, we are not using this treating COVID-19. We don't believe it's a useful solution treating this disease, shortening the course or improving the prognosis. We don't use it.
Thank you.
Okay, we will have another question.
All right, that's okay.
Jacob Chen.
Jacob Chen.
Jacob Chen.
Do we have the video of Jacob?
Hello.
Hello?
Can you hear me?
Yeah.
Yes, okay, great.
Yes.
I'm Jacob Chen, and I'm calling from Jerusalem. I would like to hear something about the discharge criteria from hospital. Thanks again for the great meeting and conference.
Okay, regarding the criteria of the discharge from hospital, now we use the following criteria. First, normal body temperature for at least 3 days. Second, significantly recovered respiratory symptoms. Third, obvious absorption and recovery of acute lesion in lung imaging. Fourth, negative result of the nucleic acid test of the virus for consecutive 2 times with at least 24 hours of sampling interval. And we also recommend that discharge cases should be, or it's better to be quarantined for more than 14 days in a ventilated single room, reducing frequency of close contact with family members. And we also recommend a follow-up at the 2nd and 4th weeks after discharge. That's all.
Okay, next is a question from America and about the ACEI habitus. I think Dr. Wu will answer this question.
Sorry about that.
Hello?
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 Oh, yes. This is Nikhil Bayani from the United States. Thank you very much for taking the time to answer a few of my questions. So the first question I had was, what do you think about the use of ACE inhibitors in patients with COVID-19? Is there any need to stop the ACE inhibitors in somebody with high blood pressure or diabetes or cardiac issues?
Actually, thanks for a question, because in the field of cardiology, a lot of doctors has different opinion about ACE inhibitor, because it's a common drug in the control of hypertension and for the heart failure patient. But there's basic research that suppose ACE inhibitor will increase the ACE2 and introduce the virus infection. But in my personal opinion, I don't think ACE inhibitor is very important, because I have experience to exchange from the pathology doctor. I think the pathology doctor give us a lot of information that there's no virus infection in the myocardium. So actually, most of the patients died from COVID-19. There's no evidence of viral myocarditis. I heard yesterday from Canada that there's a case of myocarditis in Seattle. But here in our ICU ward, more than 50 patients died, and we do some biopsy, an autopsy, but there's no evidence of virus infection in the myocardium. So I don't think that's a quite important thing to use or stop using ACE inhibitor. If the patient regularly take this medication, you just continue. Oh, that's my personal opinion. Okay.
So you did not see any viral myocarditis in your institution?
No, no evidence.
Okay. All right. And do you mind if I ask you one more question?
Sure.
And I really appreciate you guys taking the time doing this, because I have a lot of anxious colleagues I work with. The first question we have, did you guys notice some types of personal protective equipment like PPE resulted in more healthcare worker infections, like the use of N95s versus surgical masks?
Well, we most of us from Peking Union Medical College Hospital came here at the end of January. At the end of January, has been a certain experience on protection of medical staff has already been established. So when we enter the battlefield, we use PPE and N95 all the time if we care the patients. So none of us got infected from as a supportive medical team from from places other than Hubei. We believe. From the talking to local staff, we have got the impression that the outbreak or the spread among medical staff happened in the initial stage of this epidemic, and we believe two things could be the explanation of the nosocomial infection. The first one is no mask. Maybe some doctors or nurses didn't wear mask, especially surgical staff, when they do not approach patients with infectious diseases. But personally, as a doctor caring for COVID-19 patients, I would choose N95. That's also what we are asked to do. Whether surgical mask is sufficient enough or sufficient for protection or stopping the disease, we are not sure. But we believe N95 is a safer choice, given that the supply is enough.
Well, let me get one more question, just along the lines of that, because right now the CDC, the Centers for Disease Control in the United States, has recommended, because we have a very short supply of N95s, that if the patient is in a droplet precautions room, even if we don't have a negative air pressure room, we recommend the healthcare provider wearing a surgical mask and a face shield, provided they're not doing an aerosolizing procedure. If they are doing an aerosolizing procedure, we use N95s. What are your thoughts on that?
Well, we can share with you guys what we are doing. Well, there has been confusion that whether we are overprotected, because usually we wear the N95 and sometimes plus a surgical mask, and about also a facial shield if we do high risk procedures such as sputum suction, or we have to open ventilators. We will apply a facial shield. We're not sure whether we are overprotected, but you know, in terms of the results, everyone here with us are safe. We understand that, you know, at the age of epidemics or pandemics, there can be short of supply on protective stuff like N95. But we still think that, well, the medical staff should be well protected. The better, the better. That's our opinion.
Thank you very much.
Can I have, excuse me, can I have one question for our American doctor, please? Because this is my first time. I've been organizing such kind of conference many times, but this is my first time to have an American colleague to join us. So do you think it's useful? Do you think the experience is useful? And because we're paying a lot of attention to the situation in the United States, and in China, people are also focusing on what is happening on the other side of the Pacific. So, do you think this kind of information exchanges is useful for you, or do you see any places for us to improve?
You know, definitely, as the information changes, this is very valuable. And the reason I bring this up is along the lines of the N95 is because we recommended N95s all the time. But last weekend, some of our hospitals started expressing concern that we have patients who are suspicious for COVID-19, but their tests are negative, but we're wasting all this N95. And we don't have enough supply to keep up with the demand. So the CDC came in, the Centers for Disease Control, and stated that if you are not doing an aerosolizing procedure, use an N95. Use a surgical mask and face shield. And if you're running low on negative pressure rooms, keep the patient in the room with the door closed. Make sure they wear a surgical mask. So when we put this policy together for our hospitals, some of the healthcare workers felt we were taking a step back and we were putting our healthcare workers at risk. But the Centers for Disease Control clearly stated that, you know, the risk of exposure when you have a surgical mask and a face shield, when you're not doing aerosolizing procedure, is very low. It took us a long time to convince our healthcare workers about this. And I'm very happy that this timing of this discussion, thanks to Chinese Global TV Network, that we're having a discussion with you guys, because I told my colleagues that I'm going to be on a webcast with physicians who are on the front line in Wuhan treating COVID-19 patients. You're not going to believe this is the first question they wanted me to ask you.
Self-protection. Okay. Okay, good. Thank you. Thank you very much. Thank you. Okay. The next question.
I want to share with you some of my opinion about the PCR test. I think take precautions against the PCR result. You should take comprehensive consideration, including clinical manifestation, epidemiological clues, and the CT scan imaging during the diagnosis of the patients. And here in China, we treat the highly suspicious cases as if they were infectious. So we we don't release patients from the suspected cases list only according to the PCR result.
Okay, next question.
Okay, we got another question about the PCR result. Usually, the viral secretion or the positive PCR result.
Please read the question.
Okay, I will read the question first.
What is the median?
Yeah, what's the
What is the median duration?
okay? What's the median duration of viral secretion or positive PCR, and the minimum and maximum range? In our opinion, or in our experience, the positive rate of the PCR test have a significant decrease after 17 to 21 days after the infection. But in a small part of the patients, the positive PCR result will maintain in more than 1 month.
你可以解除他的命，解除他的命的，让他说话。
就点一下就行。
Okay, you can speak. We have seen your raise your hand.
Dr. Gordon.
Dr. Gordon.
Yes, this is Professor Leshem from Gordon's Computer. The question is from the Israel Emergency Outbreak Treatment Team. And the question is, we are very interested in your experience of use of surgical masks when treating suspected patients. So we don't have enough N95 to treat everybody with fever. Have you had medical team using surgical masks to diagnose patients and were they infected at all?
县市医院是可以的。
Not N95. Thank you. Over.
We have answered the second question about surgical masks. Well, we believe that in small hospitals on the county level, there are medical teams who are using only. They are short of supply of N95.
Can you be a bit slowly? Yes.
Okay. We believe, during the pandemic, especially in the initial stage, there are certain medical teams who are using only surgical masks treating fever patients in the fever clinic, just because the short supply of N95. We believe that happened. But later we have paid great attention to the protection of medical staff. So our government has tried every way to augment the production quantity of N95. What we are doing here in Wuhan is we are not short of supply of N95 in each hospital or medical center treating COVID-19. We believe. From the point of view of the results, none of the supportive team from outside of Wuhan get infected after we using N95 also plus PPE. Our opinion can be really simple. So if we can try, you guys can try your best to get enough N95, just wear them. Because medical staff are the most valuable asset in this battle for COVID-19. We want our colleagues in Israel, in the United States, all over the world, to be better protected. So it's not the time for us to accumulate or collect enough evidence, to differentiate whether a surgical mask is as effective as N95. We would like to prefer a high-level one if there are certain conditions which can be met. So that's my opinion.
I have some more information that, in China, we still have a lot of countryside hospital in a small county. And, some patient got isolated in the fever clinic or be sent home. We have social worker. We have policemen. So they wear surgical mask for isolation, for protection, or for provide health care for this suspected COVID-19 patient or suspected fever patient.
Okay, that's all. Do you have any more questions? Okay, so we will move on for the next. After hospital discharge, Sharon, is Sharon here? Is Sharon here? You can speak now. Okay, Sharon is not here, and again we have Galaxy A8.
Galaxy.
Yes, his name is.
So the learn model have to begin using when patients toleration needing mechanical ventilation. 这是个 ICU 问题。
谈我自己答对吧？你自己答就行。
Okay, this doctor answered with which ventilation mode have you begin usually when patients deteriorate and they need mechanical ventilation? I think it is ICU questions, and in this step, I think that standard oxygen therapy with the nasal oxygen is failed here, so we have to use mechanical ventilation. At first, we will choose the high flow nasal catheter oxygenation or non-invasive mechanical ventilation for a moment, and we will try to see if the patient can get better under these conditions. But if the patient didn't relieve for a quite short time, for example, about 1 or 2 hours, we may start our mechanical ventilation. And with ventilation mode, the volume control or pressure control is just you can choose or depending on your experience. And but for these patients, recruitment maneuver and prone position ventilation is very important at the beginning. Okay, I wonder if I have answered this question.
Well, I have something to add for mechanical ventilation. What we have learned from the dead patients, the patients who passed away, is we should better shorten the course from failure of a non-invasive ventilation to a mechanical ventilation, intubation plus mechanical ventilation. At the very beginning, the doctors here have the tendency to prolong the duration of non-invasive ventilation, just to avoid unnecessary mechanical ventilation. But later, we believe, due to our practice, we believe this delay somewhat lead to a high mortality of patients who really need mechanical ventilation. And after in-time mechanical ventilation, patient get relieved from the exhaustion of dyspnea and low oxygen level, so they have a better chance of weaning from the machine and get a better prognosis. That's the strategy we're applying right now. About the model, we generally obey the principle or recommendation provided by the WHO. We use a low tide volume strategy to avoid high plateau pressure. Also, we will do the H blood gas often to lower the ratio or lower the level of hypoxemia and hypercapnia. There's not too much difference. We don't believe the VC model or PC model make a really big difference here among these patients. And I also agree with Dr. Ding, what Dr. Ding have mentioned, prone positioning, and also long recruitment maneuver is quite an important strategy to relieve the hypoxemia among these patients. But one more thing to add is when you are doing the RM, just often check with the bedside X-ray, because the people may have pneumothorax or mediastinal pneumothorax after frequent RM maneuver.
Okay. I'd like to give some more information about ICU admission and the mechanical ventilation based on our data. That's the mean time from the onset of the symptom to ICU admission is about 2 weeks. The mean time from onset of the symptoms to intubation is about 17 days. And the mean time from onset of the symptoms to patient death is about 30 days.
Okay, regarding the question about the need for isolation after hospital discharge, here in China, we recommend 14 days home isolation for our discharged patients. And we also recommend them go back to the hospital for follow-up visit at their 2nd and 4th weeks after discharge. That's all. Okay. Oh, yeah, the next question is, did you routinely screen the healthcare workers to prevent cross-transmission? Yes. In our medical team, we provide the routine screening test for our medical staff to prevent, or we try to find the healthcare associated infection as soon as possible or as early as possible. Of course, none of our colleagues got infected.
Okay, we have next question from Nathan Gray. Hello, are you here? Nathan Gray, are you here?
Okay, it doesn't matter. Anyway, we have so many people.
Hi, can you hear me?
Yes.
Yes, okay.
Hi. So my name is Nathan from Haifa Rambam Medical Center from the ICU. I wanted to ask about your experience you've talked about the prone position, the importance of the prone position. I want to ask about nitric oxide, high-frequency ventilation, and the use of ECMO.
Okay. In our hospital, we don't have nitric oxide, so we have no experience of that therapy. And about high-frequency ventilation, and we have seen that during the past several years, high-frequency ventilation was not recommended in the standard treatment of AIDS, and also we are short of that kind of ventilator. So we don't have any experience of the high-frequency ventilation. But in my personal opinion, I don't think this is a very good ventilation model for these patients. About ECMO, ECMO, of course, ECMO is a very powerful technique to do the life support, such as respiratory support and also circulatory support. But we have to see that ECMO is just a machine who can release the symptoms and who can relieve the hypoxemia and hypocapnia. But ECMO itself cannot save the patients. And with the ECMO, you can start ECMO with this patient, but you have to have an experienced staff, experienced team, which combined with ICU doctors and experienced nurses. And at this circumstance, it is it's a big problem for most of the countries because all the places are short of these experienced staffs.
Yeah, I agree with Dr. Ding. Well, we medical staff are sharing opinions, our experiences about ECMO use. Since it's a very hot topic all over the world. Generally, what we have heard and what we have done here using ECMO to treat COVID-19 critical patients is very poor. Generally, the people, critical patients, the prognosis is very poor, but the ones who underwent ECMO support is poorer, even poorer than ordinary ICU patients of COVID-19. However, we have to admit the ECMO support did prolong their life for days, but generally it did not alter their ultimate result. Personally, we haven't saved a life using ECMO, right, in our ward. We haven't saved one life using ECMO in our ward.
Okay, thank you very much.
Oh, okay, we have next question about steroid treatment.
Since I am a pulmonologist, we use steroid often to treat patients like patient with ILD or even very severe community-acquired pneumonia. We love steroid. In viral pneumonia, especially in viral pneumonia critical patients, steroid has always been very controversial. We believe the academic world generally do not support the use of steroid treatment. We have tried to organize a certain kind of trial to figure out whether steroid works, but we didn't have enough time to do this. Secondly, we did use steroid treatment among various patients, but because the patient underwent a lot of treatment all the time, because we really want to help them. So it's very hard to standardize the trial and to figure out whether steroid treatment used. Personally, I have two examples to provide with you guys, or to share with you guys. One is the father of one of my friends. He was an ICU doctor. Her father got COVID-19 and had a respiratory failure, multiple bilateral pulmonary opacities, and was sent to ICU. His colleague gave his father a large amount of steroid treatment, and he also shared with me the bedside X-ray. The opacity did resolve after the use of steroid treatment. So I believe case to case, from case to case, steroid may provide some benefit to certain kind of patients, but it's hard for us to figure it out right now. We're not sure whether the patient A can benefit from steroid treatment, patient B cannot. It's hard. And secondly, because we treat ICU patient, so after like 3 weeks or 4 weeks of the disease course, we believe the viral shedding has finished. We have tested a lot of samples from the patients, including both sputum, also the nasal swab. There's no evidence for viral shedding, and also we've done bedside bronchoscopy to rule out secondary bacterial infection or secondary fungal infection such as aspergillosis. And also we have found some evidence of organization in autopsy samples. There are organizations among people's lung, patients' lung. So we believe if you are suspicious that the patient may benefit from steroid, just because you infer that the patient is undergoing the process of organization, and also you can strongly rule out the bacterial infection. Also, you believe the viral shedding is over, you can start the steroid treatment carefully in this patient. Again, I like steroid very much. I really want to use them to save patients' life. But really, I don't know which patient to use. I'm not sure whether he or she will benefit from steroid treatment. But I believe some patients can benefit from steroid treatment.
Okay.
Do you have any more questions from the Israel?
No.
No? Okay, great. That's great. So you have finished all the questions from... All right, it doesn't matter. Oh, what's wrong? Something's wrong with my computer. I think it's...
We got another question about how often did you do the screening test for the medical staff. In our medical team, at the very beginning, we provide the screen test for our colleagues every 2 weeks, and we got all the negative results. And now we actually do not provide routinely tests. We provide tests for any colleagues whenever they want or whenever they think they have some symptoms.
Exposures.
Or exposures.
And what about the result?
All negative. Oh, yeah. Regarding the laboratory test, I also want to share with you about the antibody test. In the latest national guideline, we include the IgM and IgG test as the valuable lab procedure for the diagnosis. As usually, the IgM antibody will be positive in 3 to 5 days after infection. That's all.
Okay. Is that all?
Yes.
So you have finished all the questions from the Israeli doctors. And now it's my turn. All right. Well, there's thousands of people are waiting to be answered on the internet. They have left their comments and questions on the platform Facebook, Twitter, YouTube. Quite a lot of questions, huh? All right. I will just now. Dr. Wu and I had a simple discussion, and we select about 2 or 3 questions, typical questions for the doctors here. The first one is from YouTube. The name is Wendelin Farms Wendy. Perhaps she, a nurse from Australia, I think. The question is there anything about elderly patients to indicate they may have serious disease rather than mild disease? Example, types of can you read that?
Comorbidities, medications, obesity.
Okay. Thank you. Okay. All right. Okay, you can. No, you don't have to hold this computer because Dr. Hamad is gone.
Okay.
Yes. All right. Just
indicating
yes.
that.
Yes.
I think there's a significant difference between the elderly patient and the younger patient. I can share you with my secret because I did not have showed the data, but the Kaplan-Meier survival curve between the patient over 75 and the patient younger than 75 are different survival rate. And from the data analysis, that the elder patient have higher prevalence of comorbidity, like coronary artery disease, hypertension, chronic kidney disease, diabetes. So it's not surprised that they have a much higher death rate. In our team, we the oldest one in our team who had died a couple of weeks ago. He was 92. The oldest one is 92. So the range from 26 to 92, everybody can get infected. But absolutely, the elder one patient will have higher morbidity.
Okay, good. I'm sure the answer is very good. And we have another question from Trishan Green, obviously from UK. The question is that we have been told in the UK
you cannot get it again once you have had it. Of course, it refers to COVID-19. The question is obviously about, is it possible for me to get infected again if I am recovered? All right, please.
Regarding this question, yeah, there is phenomenon that discharged patients, they got PCR test and got a positive result. But regarding this phenomenon, I personally would not use the word reinfection. It's because there is already a report about the mild cases. After recovery, they have a very robust immune responses against the virus. And second, we also have the animal model to show that the monkeys would not get recurrency after they have already have the antibody response with the second round exposure to the virus. This is the evidence from the animal model. And up to now, as far as I know, there is no report on the transmission caused by this so-called re-positive patient. And so we think this phenomenon about the re-positive discharged patients, it's because of the false negative result in their previous PCR test.
Okay, great. Thank you very much, ladies and gentlemen. I think time is almost up, and I'm so grateful as the organizer of this dialogue for your hard work in the last month and your excellent questions and answers. And it's my great pleasure to be invited in such a professional dialogue, even though I don't understand the most part of your dialogue. But anyway, I hope this will be useful for the doctors, for your colleagues on the other side of the internet. And the doctors from the Israeli side and from the US, you are mostly welcome to make your comments on the chat room of Zoom, and if you have any further questions for the doctor's answer, please just leave the questions. And if you have any comments on such kind of dialogues, please leave your comments. And if you think that we have anything to improve, just let us know. All right. And again, thank you very much. Thank you. Sincere thanks for doctors from both sides, and thank you very much also for our friends on the internet. This is the 5th cross-nation medical consultation meeting organized by CGTN, and tomorrow we'll have another one at 10 p.m. Beijing time with the doctors from the United States, and hope to see you tomorrow evening. Bye-bye.